start the recording.
Recording in progress.
Good morning, everybody. Happy Friday. Welcome to the MLAC Subcommittee on Worker Continuation of Care. It is Friday, September 16th, 2022. Meeting start time of 10:02 a.m. A little bit late. Apologies to all of you. I am Teresa Van Winkle. I am the administrator for MLAC. Thank you for being here today. I'm going to start off with introductions, but while we're doing that and get everything set up, if you are here from the provider or the MCO community and wanted to speak this morning, please put your name and organization in the chat. Or if you're on the phone, please send me a text. My cell number is 971-600-4595. I do know there's at least one. I'm just looking at names so far. I know that the Chiropractic Society may come in later. The Oregon Medical Association will try and be here during the meeting. There was a conflict, so Courtney will do her best on that. And with that, I'll turn it over to Matt and Sarah.
Thanks, Teresa. Matt, I don't know how we want to handle this today, but probably we should work on getting the minutes approved. Do you want to start there?
That sounds good to me, yes.
Okay, Teresa, since it's the two of us.
That's true. Yeah, so the motion would be to approve the minutes from the August 25th, 2022 meeting.
Okay, do we both have to second? And okay, so I move.
I second.
Okay, are we both in favor, Matt?
I'm in favor of approving the minutes.
Okay. We got an affirmative vote, no abstentions, no further discussion, motion carries. Woohoo, good work. And then Teresa, I don't know, now we're just looking for input from invitees.
Yes.
So if you want to handle that, that's great.
Yep, I can do that. And I will start off for the group. So what I have done is to kind of help balance our allotted time with the wide variety of provider groups, type A, type B, I invited all four of the active MCOs in the state. And also they're all currently active, and also a number of groups. There are some groups that were unable to be here today, or this is kind of subject matter that they wanted to listen before providing input. So I would consider this probably part one of a conversation, if you will, on things, on that. Also, to help with kind of giving some direction on and some continuity on topics that to be presented today. I sent to invitees and had it available my semi-organized thoughts of different ideas and topics that came up during the first meeting, and also follow-up requests. And so that was distributed. And I'm actually going to upload in the chat in a second. Caremark, one of the four MCOs, submitted written testimony that was based upon my questions. So I'll upload that to the chat. So for Jeff and Brittany, that is going to be uploaded to the website as well, but it came in early this morning, so it's too late to distribute tonight, so I apologize for that. I was going to say, so Matt, Sarah, do you have a preference to what group to start? So if you want to start with the MCOs that are here, so I do have, so there is Caremark and Majoris are here, or do you want to start with the provider groups?
I don't have a preference.
Okay.
No. But also Teresa, just to note, we believe that the MLAC meeting next week can be a holdover meeting, so we could use that as well for continuation of testimony. Someone could make it today, or if there's not enough time.
Yes, and I will also too, as the conversation continues, for transparency, I will put in the chat organizations that had invites, and then any other organizations that contacted me as well.
Great, thank you.
Okay, great. So I think I'm going to, since I don't think there are more, we'll start with the provider groups, because there's probably some questions from the that come up during that part of discussion that will dovetail into questions for the MCOs. So we'll go with that. So going down the chat, I will start with Rachel Staffler from the Oregon Society of Physician Assistants. Good morning, Rachel.
Good morning. Thank you so much for letting me have the opportunity to speak today. Do you need to give them a little bit background on who I am? Would that be helpful?
That would be great. Thank you.
All right. So I'm Rachel Staffler. I'm a physician assistant. I work in Coos Bay. I'm an outpatient internal medicine, but I'm also a hospital-based provider. I also work in the pre-hospital care setting. I also work at Curry General Health in Brookings at a standalone ER. And then I'm a reserve police officer for the city of Myrtle Point. And I also work interagency for opiate reduction. And I am a consultant for the Oregon Medical Board. And I'm the OMA Physician Assistant of the Year. I have a very, very large internal medicine practice of almost 3,000 patients here in Coos County. I've been here almost 15 years. I took on the first responder role approximately 6 years ago. I worked in workman's comp before within another career, so this is kind of near and dear to my heart. I have about 60% of the first responder patient population in my county. And what we're finding as a physician assistant, only being able to care for this 60-day block versus the entire block, is really big disruptions in continuity of care. So what this is doing is creating some barriers for our patients, who sometimes are kind of their most vulnerable spots. Sometimes our working comp injuries aren't always a physical injury. They can be a psychological or emotional injury as well. And so what that does is it can really create a lot of barriers. It creates a lot of room for medical errors and miscommunication. We're having to change providers partway through care, and that can lead to a lot of lack of confidence in our patients, lack of trust with the other providers, having to explain their story and the whole situation again, as well as just kind of a generalized frustration. One of the other things too is it really pushes the increased cost. I think we're really losing a lot of the dollar here, which is not the most important part. The patient's the most important, but we have to be fiscally responsible as well. And what happens is by changing over waiting providers and then this complete disruption, we end up increasing costs that goes directly to Sept and to the patient. And so that's obviously a big concern for all involved. The PAs are a large portion of the rural workforce, and this not being able to have this total continuity of care is creating quite an issue for us, especially in rural Coos County. There are minimal Majoris providers in Coos and Curry County, both. There's a big list of them if you go and look at the Majoris website, but 3/4 of those providers have moved. I only have 2 providers, at least in my clinic, that are willing to take Majoris patients, but they're booked out 3 to 6 months. So, I'm the lead occupational injury and exposure clinician for Oregon State Police. So I manage the entire divisions of Oregon State Police, including the fire marshal's office. So anytime somebody gets hurt, they have a bloodborne exposure, officer-involved shooting, mental health injury, I'm the clinician that gets called for that in addition to our mental health resiliency unit. And it really, not being able to care for these patients for the large proportion of their care has been a real struggle and a great frustration for all involved. So thank you. I really appreciate you letting me take some comments.
Thank you. So, members, you have any questions for Rachel?
Yeah, I was just wanted you to repeat that. So there's only 2 providers in the region that, so that would be physician providers that would see the Majoris patients. Is that, which region is that? Like, is that Coos Bay, Coquille, all of that, like from Florence down? Or I'm just wondering what kind of geographic space that is.
So that's going to be Coos County, Coos Bay, North Bend, Coquille, Myrtle Point, and Powers.
Thank you, and thanks for all your service. You sound incredibly busy.
Well, thank you very much. Appreciate it.
Okay. Thank you, Rachel, again. Let's see. So I'm going to go down the list. So Caitlin, I will bridge you in between the provider groups and MCOs. So we now also have from the Oregon Society of Physician Assistants, Elisa Gifford.
Hi, thank you, Mr. Calzio, Ms. Steckel, and members of the MLAC Subcommittee and Workers' Continuation of Care. On behalf of the Oregon Society of Physician Assistants, we would like to thank you for the opportunity to speak to this challenge of ensuring continuation of care. My name is Elisa Gifford. I am a practicing PA, a former OHSU faculty member. I have also practiced in family medicine, inpatient infectious disease, and now I do skilled nursing care. I am also president-elect for OSPA. OSPA appreciates the willingness of the Management Labor Advisory Committee to consider the issues of continuation of care and develop improvements to the benefits of the workers, employers, and medical providers. As shown in the attending physician status chart provided in the meeting materials for today, physician assistants may only serve as an attending physician for 60 days or 18 visits before having to hand over the patient to a type A attending physician such as an MD or a DO or a DPM. This limitation of physician's ability to provide care represents an arbitrary barrier that no longer reflects Oregon's integrated healthcare ecosystem. As a result of the Oregon's legislative passage of House Bill 3036 in the 2021 legislative session, physician assistants now have a collaboration practice model that grants greater latitude for PAs to be primarily responsible for patients' treatment. Updating our workers' compensation system to parallel this reform would improve continuity of care by allowing PAs the ability to treat patients for longer without having to turn patients over to another provider after a short time. Physician assistants play an important role in addressing rural and underserved communities' workers' compensation claims. In the current system, patients must deal with longer wait times as a result of the need to transfer care. The transfer of these cases creates pressure points for communities without many type A providers and lowers the efficiency of which the patient's needs are addressed. Equally as important, the need to transfer care negatively impacts the trust built between patients and providers, as the patient must create a new rapport with a different provider than their initial attending physician. OSPA plans to introduce a bill in the 2023 legislative session to address some of these concerns by increasing the amount of time physician assistants and nurse practitioners are allowed to treat worker compensation cases with the goal of improving continuity of care. OSPA would hope that this subcommittee continues its important work of revising and improving the Oregon workers' compensation program, and we look forward to being a partner and resource of these ongoing efforts.
Thanks, Elisa. Members, do you have any questions?
I do. You mentioned that these were arbitrary barriers. Is there anything in the literature that suggests outcomes are different for patients who are experiencing like work comp claims who see a PA versus an MD? Is that established somewhere, or it is? I'm just curious because you had mentioned arbitrary.
It prolongs, I would have to find the exact studies, but it does prolong the time that they're in workers' comp because they have to redevelop new trust with a different provider, and then they're delaying care of trying to get into another provider. It's definitely preventative of improving their care.
So that's related to the actual transfer of care. And so with outcomes-wise, like I know like with chronic illnesses, we can see that physicians assistants and nurse practitioners have equal or better outcomes than primary care physicians at times. So I'm just curious, are there any studies around like work comp around outcomes based on what type of provider is seen? Not necessarily that transition that is being mandated now, but in literature that may allow it to be comparative of a physician's assistant seeing a patient, equal patients, like what the timelines look like, or outcomes. Are there any differences that you're aware of?
We can definitely follow up on that. I know AAPA has been researching that, and we can definitely follow up and provide you with that information.
Thank you.
Any other questions? Once, twice. I'm just checking on the other screen. Okay. Thanks, Elisa. So I'm going to ask again for those who jumped on into the virtual room a little later. If you are here as in the provider community or an MCO to present information to the MLAC members, please put your name in the chat so I have that. So that is the last that I can see in the chat for in the provider community. Let's see. So I didn't. Oh, let's see. Okay. All right. So I will now turn it over to the MCOs, and first we have Lisa Johnson from Majoris.
So I just wanted to start by saying there were sort of three main questions that were pointed out to us when asked to speak here, and the first was how MCOs are managing continuity of worker care, and then if we are taking direction from nurse care managers regarding continuity of care, and then what the processes look like on the MCO end, preferably from the perspective of the nurse case manager. And I'm really only going to address the first one because at Majoris, each claim is assigned to one person who's responsible for oversight of the claim, but all the utilization review decisions are made by physicians. So they have access to physicians, and that is who makes any, if we need to make a call, for example, on the appropriate level of care for a worker. Overall, I think there are several main times when continuity of care can come into question. And the first would be at enrollment. And that's, for us, a large majority of workers at the time that they're enrolled, they're already treating in network, so there's not a change. However, there are times when they're treating out of network, and there's a couple things that can happen with that. So first of all, if their provider does fall into the come along portion of the rules, then we go ahead and we send that paperwork to the provider, and essentially that's just asking the provider. You have a question? Oh, okay. Sorry, I thought.
No, I thought the same thing. So please go ahead.
Okay. So for a come-along provider, the main thing they're agreeing to is for any referrals for ancillary care, those are going to be referred in network. They're going to follow reporting requirements and also pre-certification rules. So during the time that offer is made to that provider, the worker continues with that provider, so they're not needing to change at that time. If they need to change, either because the provider doesn't qualify or because they decline, the worker then gets 14 days to still stay with that provider while they're establishing care with the network provider. And at that point, depending on the worker and their, I guess I'll just call it their overall medical savvy and their comfort in that area, they can either use our searchable website where they can request a list, but also the MCO is available to help. So if they want some help with finding a provider or scheduling, or they're not quite sure, they're thinking, well, I've been seeing, for example, a chiropractor, I'm thinking maybe I want to go see Ahmed or something, they can talk to us about that, and then one of the physicians here in our office will take a look at what's happened so far and can make some recommendations on what types of providers they should be seeing going forward for their claim. There could also be during the claim, sometimes something comes up and there needs to be a change. It could be the worker choice because they want a different attending physician, or maybe the workers moved to a different area of the state and so it's just not convenient to continue where they were before. Also, sometimes it's for a change with the provider because either the provider themselves have retired or maybe moved to another practice, or occasionally it's because they discharged the worker from care, either because of the worker's behavior in the clinic or because they really just feel like they don't have anything else to offer. They've said med-stat and the worker still is wanting to go in and treat, so they discharge them. And then there's also could be a change in circumstance. So maybe the worker had new conditions are identified, for example, and so now it's better for them to go and see a surgeon. And so again, usually their attending physician at a time is going to facilitate that by making a referral to the right type of provider. But if the worker wants some help with that, then the MCO again can help with scheduling and finding the right type of specialist for them. And just wanted to point out when I'm talking about that, the MCO will make recommendations on a type of provider. Like we might say, okay, this point is better for you to see an orthopedist, but we don't choose or designate an attending physician. So the category is put out there, and then the worker still gets the overall choice of which doctor they want to see. And then not so much with needing there to be a change, but sometimes just with ongoing care on the claim, there can sometimes be some issues with access due to scheduling conflicts. So that could be the provider schedule or the worker's schedule. Could be the worker is failing to schedule timely or they're not showing up for their appointments. So we saw a lot of that kind of exacerbated during the pandemic, just with provider offices having some staffing issues, but also with workers, they got exposed or they just don't want to go out. And that seems to right now be kind of calming itself down, and we're moving back into a place where that's not such a constant issue. One of the bonuses that came out of that is a lot of clinics became a lot more open to figuring out how to offer telemed to their patients when that's appropriate. So that's been something that's come up, which can actually be helpful too. It can be more convenient for workers when they can do it over the computer and not have to go in either leaving their home or working or leaving their employment. I do want to point out that one of the advantages with all of these issues is when a claim is enrolled with the MCO, besides scheduling assistance, the MCOs are consistently assessing our network adequacy for provider access in each geographical service area and for the types of providers in those areas. So when you're looking at our list of providers, those are, we're not, for example, listing all family practitioners in the area. Those that are on the MCO list are the providers who have indicated that they are open to seeing injured workers. So that can cut down on a worker who's looking to find somebody new. That makes it a little bit, it narrows it down for them so they're not making calls and ending calls trying to find out and just hearing that that particular clinic or provider is not injured in treating workers. The other thing for MCO enrolled workers is one of the things that an MCO considers important to our network management is also provider education. So making sure that they're aware of how important their part is for the workers and seeing them regularly and addressing especially issues like return to work and providing those physical capacities and or limitations so that the worker and their employer can figure out if there's something that they can be doing and not be just at home, and they get them back into the workforce sooner. And then also just depending on provider availability and clinic workflow, the attending physician in some of those clinics, in order to help with the access to care issues, they'll share those responsibilities with a PA and or NP in their office, so they're not necessarily seeing that same physician every time, depending on provider availability and what level of care is needed for that next visit. Okay, any questions on any of that? That was sort of a lot, and I talked fast. I apologize, trying to get it all in there.
Lisa, this is Sarah. I do have a question. Can you speak to how often the NCO patients and Majoris are seen, and if there's any issues with that scheduling?
So we require our physicians to see, as long as a worker is not released back to regular work, our expectation is that the provider is making themselves available every 30 days or sooner so that they can evaluate the patient and update their treatment plan, update any physical limits or capacities that they have. And again, that might not be their attending physician, it might be another provider in their office. And for the most part, in general, that's what's happening, and that cadence gets set up, and then when the patients, when they're done with one appointment, they're making their next appointment. There are times when that doesn't happen. Usually it's just because the appointment doesn't get scheduled. The worker leaves without scheduling it, they're not ready to schedule it, or sometimes the worker just doesn't show up for the appointment for one reason or another. When that happens, there are different ways that can be addressed, depending on what's going on with the claim. A lot of times it's just a nudge either to the provider or the worker to say, it's time to get scheduled. The adjuster has some administrative tools that they can use if the worker's just not going in at all, in order to either make a mandatory appointment where they send what they call a bug letter to just say, if you're done treating, that's fine, but if you're not, please let me know when your next appointment is. Overall, while someone is still released to get a modified work or no work at all, they're being seen at least once a month.
And you see no continuity of care issues in making this happen on that 30-day turnaround?
glad you're asking me that now and not a year ago, because it really was a different picture then. That was kind of a big struggle for a while. They pretty much have gotten back to that same cadence. It's not that it never happens, and when it does, then either the MCO is getting involved, the adjuster, or something's happening to try and make sure that the worker doesn't just, fall off and have these gaps in care. But generally the 1 month cadence is pretty much back in play these days.
This is Matt. I just want to clarify, in that 30 days, they're not necessarily seeing their attending. They may be seeing somebody else in the clinic, the NP or the PA.
Right. And that kind of depends on the way the clinic is set up. So with some clinics, they see the same provider pretty much every single time, unless there's an absence or something unexpected going on. But with a lot of clinics, they'll have, I guess I see it a lot in orthopedic clinics where, after surgery, for example, they'll see not the surgeon at the initial follow-up appointment, and then maybe they'll see the surgeon, and then they kind of get into an every other month kind of pattern. But it really is up to the clinic how that works. And we do also reserve the right that if it's just not seeming to be going right, and we want to make sure that it's the MD that is seeing the the patient at the next appointment, we'll reach out to the clinic and let them know that. That's not a very frequent occurrence.
Go ahead, Matt.
And I guess, sorry, go ahead.
I was just, it sounds like you do a lot of work on that provider end then. Is there any incentive or consequence on the provider's end if the worker isn't making it to the 30, getting scheduled for the 30 days? Or, 'cause it sounds like there's a lot of education on that component, and I'm just wondering what else you all do to keep that cadence going.
It is mostly a focus on education, because usually when we have claims where the worker's not getting seen regularly, it's not the provider that's not available. It's not that never happens. That sometimes there can be, issues with the clinic, the provider being unexpectedly out, for example, and their coverage person being very busy with their own practice and recovering. But usually when a worker's not being seen, it's either because they're not scheduling or they're not going to the appointment. So it's not something that we put on the provider. That expectation is out there. We want them to be available to see the workers, and we explain to them why it's so important. But usually when there's the delays, that's actually on the worker side, once care is established.
Lisa, this is Sarah again. Can you speak to the administrative tools of how effective you feel they are if a worker is not coming in for appointments or is not scheduling? You spoke to the bug letter. How effective are the administrative tools in dealing with these issues?
It kind of depends on the adjuster and how well and timely they're using those, and sort of what the reason is. So we do see a certain number of claims where they send the bug letter because the worker's been back at work and they're just not really treating, and the patient doesn't really feel the need. They're like, what? I feel better. I don't want to go back in. I don't have time. So they'll send the bug letter, and then the adjuster will use that to close the claim. I think that usually the adjusters are pretty reasonable, where if they send it out, essentially what it's saying is, looks like you're not going in and getting treated. Can you please tell me when your next appointment is, or if you're not going to be getting care? And I'm not exactly sure the language because that's sent out by the insurance company, and I'll have just a little bit of a variation on that. And usually when that happens, either the patient will call their adjuster and say, I actually don't want to go in anymore, or they say, yes, I am, and they'll say, I just called, I scheduled an appointment, I'm being seen in 2 weeks or 3 weeks or whatever it is, here's what my appointment date is. So sometimes it's just the nudge that's needed. Sometimes there is. So sometimes maybe I've seen a provider who wrote an open-ended time loss authorization, and so the worker might not be feeling especially ambitious about getting back in because they like what the status is. But the adjuster's not going to necessarily want to close it on a bug letter because we know that the worker does still need more care. That's not in the best overall interest of the patient. So when something like that happens, there are times when we will get involved in that and have one of our physicians take a look at it. And if they say, yeah, there is still more care, it does need to happen. Here's who the worker needs to see. They should go back and see their attending, or maybe at this point they should see a specialist, and here's what kind. Then we can actually schedule an appointment and the adjuster can make it mandatory. So it depends on what's going on with the claim, how it gets handled. Sometimes it's a bug letter, sometimes the adjuster can just make a mandatory appointment in order to make sure that their patient is seen.
Thank you. And then I think I have one more question. Rachel spoke to the lack of providers in the Coos Bay area. Is that an issue for access to care down there?
That is one of the trickier areas of the state. So yes, and what we can do is we can send something in writing and provide you some actual numbers with what's going on there. That's it's also one of the areas where sometimes it's tricky to stay up on because sometimes the clinics forget to tell us this person moved and now they're at this clinic and not this one, or they are limited to existing patients only, for example. So it's actually an overall access problem, not necessarily just for work comp, but definitely something that keeps our provider relations department on their toes.
Any other questions for Lisa? Okay. And so I believe this is our last. I'll do another round of asking after Rhea speaks when we finish Q&A. So Rhea Schnitzer from Caremark, and there is the written comments from David Pyle, so I will upload those right now as during the conversation with Rhea.
Hi, this is Rhea. Actually, I didn't have any type of presentation. I put my name in just in case there were any questions. You would know who to call on.
Okay, thank you. We'll just take me a second to upload. You caught me off guard. So I'll do that right now. Okay. So there's that. Is there anyone else here from the provider or NTO communities that wanted to speak? Going once, going twice. He's checking it's okay. So that person. Okay. So I think that's it. I do have a couple of comments too before we move forward with the subcommittee discussion. Just again to reiterate what Sarah mentioned, the next subcommittee meeting will replace the standing meeting date and time for the full committee. So it's next Thursday, I believe. I have all these papers in front of me, but I will put that in the chat as well. So I do know that a couple of providers, let's see, so I just going to check here one more time. There is a chance that the Oregon Chiropractic Association, Dr. Vern Sabo may be joining the meeting. He's going to try and do such in between treating patients on there. I also have some post-meeting conversations with the Oregon Association of Naturopathic Physicians and also with the Oregon Medical Association. Actually kind of dovetailing other requests that came from during the first committee. A number of MAC members are also members of OMA. And so also in a voicemail from OMA, there's also the thought of also potentially bringing for information clinical staff as well to speak to the subcommittee in regards to that, because they are the ones that deal with day-to-day with some of the clinical areas such as scheduling and such. So I will coordinate with OMA on that. Hopefully we'll get that squared away and get the presentations ready to go for our next subcommittee meeting. And so with that, and also too, shifting before transitioning within the written exhibits, it's on the MLAC subcommittee webpage is minutes from the last MAC meeting. They were referenced a number of times during the first subcommittee meeting, so that is there. There is also WCD Workers' Compensation Division staff for the MAC. So if there's any questions that arise that are specific to MAC, please, staff, feel free to chime in and be my lifeline on that. So another question from Matt and Sarah. Do you want me to go through the other written exhibits from the department that would have been distributed on the website?
Sure, I think
Okay.
that could be helpful.
Okay.
Thank you.
You're welcome. So the first, and I apologize, I can't speak and upload things at the same time. The first exhibit that is on the website is a chart. So this is from the end of August of 2022. It is the current attending physician status for the various attending groups, the two groups of attending physicians, and also ancillary providers. I'm not going to read all of it. So there are two types of attending physicians. Type A, which consists of the credentialing of medical doctors, doctor of osteopathy, osteopaths, oral and maxillofacial surgeons, so head surgeons, those who deal with that, and also doctor of podiatric medicine. So those four provider groups have full attending physician status, can provide compensable medical services for initial injury and illness, authorize time loss, establish impairment findings, and provide compensable medical services for the aggravation of the injury or illness. This group of attending physicians are the only groups that do not have to review educational materials and certify with DCBS to provide workers' compensation services on that. On the flip side, you have what's called the Type B attending physicians. Those are comprised of physician assistants, naturopathic physicians, and chiropractic physicians. They can have attending physician status outside of an MCO and their standards and practices. Attending physicians in the Type B categories can be attending physician for a total of 60 consecutive days or 18 visits from the date of the initial visit on the initial claim. There's also restrictions on how long they can provide compensable medical services, how long they can authorize time loss. They also cannot provide impairment findings unless they are a chiropractic physician. They also cannot provide compensable medical services for aggravation or injury of illness. Yeah. So outside of that, the ancillary providers cover a very wide range of provider groups, starting off with nurse practitioners, emergency room physicians, and other healthcare providers. So there are specific criteria in regards to their role in the workers' compensation system for emergency ER physicians and nurse practitioners. Emergency room physicians do not have to go through the educational review and certification process with DCBS, but nurse practitioners do. The other difference between things to highlight between ER physicians and nurse practitioners can provide compensable services for up to 180 days from the date of the first visit. They also can provide authorized time loss for up to 180 days from the first visit. Emergency room physicians can provide compensable services, but they cannot be the attending physician, and there are specific conditions in which they can authorize payment of time loss. For the other healthcare provider groups, they can provide compensable services for 30 consecutive days or 12 visits from the date of the first visit of an initial claim. After that, they can provide services, but only if it's authorized by the attending physician as part of the attending physician's treatment plan for the worker on that. And then also all these ancillary groups have to certify with DCBS. So there's that piece. So I apologize. I need to go back to my phone here and make sure I'm not skipping any of the supplements, the documents here. There is also, I'm not going to go through this, but there is a document on the webpage that provides a chronological history of attending physician status in workers' compensation, starting from 1990 up until the last change, which happened in, in 2013. That was when the nurse practitioner treatment and temporary disability authorization statuses were established there. Also, I think I mentioned the MAC minutes, and then last but certainly not least, Elaine Schooler from Sept submitted some follow-up information on that. So what this is, it's the statutory provisions that were provided by the Oregon Trial Lawyers Association. I'm just reading directly from the cover letter. So again, statutory provisions provided by Trial Lawyers Association to negate the need for legislative action on open-ended time loss authorizations. So I won't go into that. Elaine is here if there's any questions. Also, we do have WCD staff that are here, subject matter experts, for any questions that you may have during discussion.
Teresa, can we go back first before we get to Elaine on the MAC minutes?
Yes.
Will we have anyone from MAC here at some point to talk about their position?
I believe that is the plan. I apologize, I have not had the opportunity to talk to staff. So I'm not aware of when their next meeting will be. So if anybody...
Could we invite a doctor from the committee?
We can do that.
I mean, who has been invited?
I have not done any direct invitations. I believe that the members are aware of the work of the subcommittee, but I certainly can send the invitation.
And I would like to know, I mean, we got their minutes, but I would like to know from a committee member their position.
Okay.
Verbally. Matt, I don't know how you feel about that, but yes.
Yeah, I would agree that it'd be interesting to hear from them.
Okay.
So could we try to get them here, someone? I mean, there's a whole list of names. Maybe even Dr. Bauman would be possible next week.
Okay. We will work on that to come meeting conclusion. Hi, Sally.
Hello, hi, Teresa, jumping in here, Sally Cohen from the Workers' Compensation Division. The next MAC meeting, they meet every quarter. Their next meeting is scheduled for November 18th, but in the meantime, we will reach out to them and see if anyone is available to attend the subcommittee meeting or not.
I think it would be helpful to be able to have a conversation with them. I mean, their meeting minutes suggest their intent and their wishes, but having that conversation is always helpful.
Okay. Are there any questions about any of the other written exhibits from the department?
I'd like to hear from Elaine, if possible, from Faith on her thoughts and follow-up.
Hi, Elaine Schooler with Sept Corporation. I did provide a summary of the statutory provisions that were provided by the trial lawyers at the last subcommittee meeting. These came from discussions we had last year regarding open-ended authorizations and other tools that may be available to insurers when workers are having gaps in treatment for various reasons. So it starts off with a number of statutory provisions, the first being failure to appear at an appointment that's been scheduled, and that the worker is then notified that time loss benefits can be suspended if they don't appear at a rescheduled appointment. That can be problematic if the initial appointment is never scheduled, and that applies to claims that are enrolled in the MCO and non-MCO enrolled claims. So if those workers don't have an initial appointment to return to, there's not that rescheduled appointment. That can be used as a provision to encourage the worker to follow up with their provider. And so that does create a barrier for the progress of the worker's care and their ongoing improvement. The second provision is requesting updated medical reports from the provider every 15 days. Yes, this can be requested. However, it's a tool that when the provider is not seeing the worker or having any contact with them, telemedicine, video conferencing, often our attending physicians can't comment on the worker's ability to return back to any type of modified work if they're on a total work release, or if the worker is performing some degree of modified work with the employer, verify that that those restrictions remain appropriate, or if they need to be tightened up if the worker's having some problems with them, or if they can be loosened and the worker is capable of doing more. The third provision it allows payments to be withheld if the healthcare provider cannot verify the worker's inability to work. We run into a similar issue here where providers are not willing to readdress work restrictions and work releases without having that contact with their patient to see how they're doing, how their recovery is progressing. It's just a continuation of what restrictions were already in place, even if the worker has not been seen for a period of time. So while this can be used in some situations, it's often unsuccessful in getting any type of adjustment, appropriate or otherwise, when the provider hasn't been able to connect with their patient. The fourth is withholding payments to healthcare providers who don't report on the worker's ability to return to work. This one we feel would actually push providers away from treating injured workers, a punitive tool for them, and disincentivize them to treat workers within our system. So that seems to be counterproductive to the goal of keeping providers in the system, encouraging contact between the provider and the worker, and ensuring that workers are improving and seeking treatment appropriately. The last, number 5, is claim closure when a worker fails to seek treatment for a 30-day period unless they can demonstrate it's beyond their control. For example, a family illness or other personal issues can get in between those appointments and cause them to be rescheduled or missed. And so when that happens, the insurer could close the claim. This too is one of those provisions that really doesn't aid the worker from our perspective in their recovery. As noted by Lisa Johnston, really the goal is for the worker to recover from their injury, to be able to get back to work. Claim closure closes their claim. It would stop their time loss benefits and re-impairment, but it doesn't get to the root problem, which is workers who are in need of treatment and are not receiving it. So we feel this is not, the most useful tool to aid in workers remaining connected with their providers, seeking appropriate and timely care. I'm here to answer any questions the members may have.
Thank you, Elaine. Yes, this is Sarah. I do have a question that maybe you and Lisa would like to follow up. I heard her say that open-ended time loss sometimes leads to workers not especially being ambitious to get back in. Or do you experience the same issue on your side?
Well, I can't personally speak to the motivations of workers and why they may not schedule their appointments or attend follow-up appointments. But we do have cases where there are prolonged gaps in treatment, and it's unknown to SAFE and the claim adjuster why the worker is not going in and being seen when they're on time loss benefits. And in those instances, from the cases that I have dealt with, it is cases where workers have ongoing problems, need ongoing care. They haven't made a full recovery, so that those gaps can become problematic from the sense of the workers getting better.
Thank you. And I've heard from Lisa and you that in these instances that workers still need care to get better, you're really reticent in closing those cases, even with the tools you have, because it's not in the best interest of the worker. Is that correct? Did I get that correctly?
Yes, yes.
Thank you, Elaine. This is Matt. I just looking at. I guess my question is there a gap in with all of these tools? Is there a gap in here that is in some of these instances, which haven't ever seen really quantified in helping workers stay connected with care? I'm just looking at the tools with letters and kind of a lot of these guidelines with time frames. So where would there be a gap that you all envision that workers are unable to stay connected with their care?
Oh,
I guess in this framework of the statutory abilities and tools available.
so if I'm understanding your question, you're looking for like examples of how gaps occur throughout the worker's treatment?
Or rather, like what you've exhausted all of these tools and there's still something missing. It's because it seems like this is a pretty comprehensive toolbox to stay in contact with the worker and the provider and kind of have these guidelines set up and ways to address if things are kind of getting off course. So I'm just curious, what else would be necessary to help ensure that we have that continuity of care?
Sure. I think the comments from Lisa Johnson at Majoris that studying that clear expectation of treatment expectations can be very useful. As she commented, having the providers use that as their best practice for seeing workers who are on time loss, 30-day period, and that they see success with that. I think that would point to an added benefit of having a treatment period in place that sets that expectation for workers and their providers. Some of these provisions seem to be more broad, in particular the claim closure piece of just closing the claim, shutting off the medical benefits, the spectrum of medical benefits that workers are entitled to once their claim is closed is different than when the claim is open. The other pieces too for suspending time loss hinge on appointments that may or may not have been scheduled in the first place. So those tools have limited availability, and that creates gaps where that tool is not available at all to the insurer. They also can cause these gaps to continue while the insurer goes through this administrative process. The notices that have to go out are highly technical, and strict compliance is required for them. And so for instance, with a worker is receiving the notice, if the rules haven't been followed in perfect succession, then the time loss benefits would continue, and still that care is not being received. So I think that creates an impediment too.
Thank you.
Okay. So where do we go from here? I guess I'll touch a lot.
And that's what I was going to ask if there's anybody from the trial lawyers.
Yeah, that was my thought too.
Thank you.
Yes, thank you, Chair. Thank you, everyone, for being here. I'm Javon Patrick with Oregon Trial Lawyers Association. I do appreciate listening in on the discussion here. I just wanted to raise a couple points that came up for me. We did go over the list, and although from our perspective, although one tool in and of itself may not be enough, in concert, one tool here, one tool there, seem to be sufficient to get most workers to comply. And we don't want to create new rules that will penalize the majority of compliant workers so that we try to catch those few DACA dodgers that are out there. I did want to comment that there are a few additional tools that were not addressed in the list because there's just a lot of them. The main one is the bona fide job offer, offering the worker modified duty. Even if the doctor has the worker off of work completely, there's nothing stopping an insurer and an employer from creating a modified job, sending it to the doctor, and then if the doctor approves it, offering that job to the worker. That is going to get the worker back into work, back engaged. Another provision that wasn't mentioned was the insanitary practices, that's 656.3252, where the insurer can notify the worker if they're engaged in insanitary practices that can lead to suspension, and that can trigger the worker to get back into that treatment. Another tool that can be used is enrolling the worker in an MCO. Now, we heard a presentation here from the MCO. It sounds like they have a lot more tools at their disposal to get workers engaged with treatment, including setting the appointments for them. So that's another big tool that insurers can use with those few doctor dodgers that are out there. Again, I think Mr. Calzia mentioned, we haven't heard statistics on how common this is, and I can tell you that the grand majority of my clients all really want to go to their medical treatment. They want more visits, not fewer. And on the MCOs, listening to their presentation, it certainly sounds like the MCO is very hands-on in working with the providers and the workers to schedule those appointments, and that even they have difficulty sometimes getting people in. So that hands-on approach, I think, is very important for us to note, because this is this is not the worker and the doctor alone. This is the worker, the doctor, and the insurer. And the MCO, when asked about tools, they said it depends on the adjuster. So we have a lot of range in what insurers are actually deciding to do as far as utilizing all of the tools they already have at their disposal. I'd also like to point out some of the tools that were mentioned by Sept Corporation and why they didn't want to use them. For example, they can't get the doctor to respond and change work restrictions in between appointments. If the insurer who's paying the bills does not have the ability to change the doctor's mind midstream, how is it even conceivable that the worker, who has much less power, would be able to do that? If we have a set amount of time that your time loss authorization expires, no matter what, on some date, and the expectation is that the worker can somehow convince their doctor midstream to, in the middle of appointments, to get a new work release when the insurers have come forth and said they can't do it. I think that is a real danger point in considering that. I think we also need to recognize that some of these tools that aren't working, it's not because the worker is not engaged with their treatment. It's because the doctor doesn't think they should be released. The doctor doesn't think they need to see them until they finish that physical therapy or they finish that MRI or whatnot. That's not the worker's issue. It's not the worker being disengaged in continuation of care, and that problem will not be solved by cutting a worker off of time loss at some arbitrary date. Sorry, I lost my train of thought there. So, I think the discussion about setting clear expectations and working with the providers is important, but we should not put the onus and the punishment and the penalty on the worker when, according to the insurer, a lot of this stuff is in the doctor's hands and out of the hands of the insurer and certain of the worker. Thank you. I'm happy to answer any questions.
Thank you. I don't have any questions.
Thanks, Trapana. Go ahead, Elaine.
Thank you. I just wanted to sort of address some of these other provisions that were mentioned for the bona fide job offer. I would be very surprised to see a treating physician change a worker's work restriction from being completely off work to a modified role without having any contact with the worker in advance to go over a modified position that is going to be offered to them by their employer. And if that is happening, that I'm not sure how the doctor could make that determination on appropriate modified work restrictions without reviewing it with the worker in advance. The contact piece, in my experience, is essential and involves a conversation between the doctor and the worker to determine the appropriateness of that. I can't speak of all the cases, but I'm not sure that I've even seen this happen in a case where a worker has not continued care with their provider and the provider unilaterally approving modified work. But it could happen. I think many of our providers would be hesitant to do so, though. For the insanitary practices and leading to suspension, that's a difficult piece. It's hard to define what insanitary practices are, and that just a failure to treat may not rise to that level. Workers can be enrolled in the MCO, but not all claims are enrolled, and that can be for a variety of reasons, depending on location, specialty, availability of providers. Worker may be enrolled in an MCO and then receive a referral to a specialist, and that causes a disenrollment so that they can treat within their geographic location with that specific provider if they're not offered. So while the MCO does provide assistance for those claims, for the claims that are not subject to the MCO, that tool is not available. And then not being able to get the doctor to respond or having the worker do that, we're not asking the worker to get the doctor to respond. What we're asking is for the worker to participate in their care while they're recovering from their injury. That seems to be a reasonable request. When workers are hurt on the job and recuperating, they should be involved in their care and having conversations with their doctor about their improvement or setbacks that they may encounter, so that care can be adjusted. And when that conversation isn't happening, that can lead to poor outcomes for the worker. I think those are the extent of my additional comments, but again, I'm available if you have questions.
This is Matt. I do have a question for maybe all of you, including Ms. Johnson from the MCO. Regarding that, was it bona fide job offer is the term that was used? I'm thinking of our memberships of registered nurses, and what could happen is a nurse could experience an injury in the hospital, and they would be 100% off of duty because of something like they're unable to do compressions in the event that they would need to for CPR. So they may have, that may be like really the big reason that they're not allowed to go back to work. And then the employer may say, well, they see the nurse sees the physician says you're totally off work. And then the employer may think, oh, I can have them audit charts, which requires sitting at a computer and just going through the auditing, all of the input from other nurses and flagging discrepancies. And so in that instance, it doesn't seem like with the insurer reaching out to the physician that they would need to then see the patient again. They may say, oh, that does seem like an appropriate bona fide, work that they can do, and you could make that job offer. So I guess I'm wondering from the MCO standpoint, because they may manage it somewhat differently, if that is something that would happen that you see on a regular basis, or where you see that kind of, they have the initial assessment from the physician, the employer then thinks of a job offer and connects with the physician to see if it's appropriate based on that. And because this is the first I've really understood about this bona fide job offer situation.
So the MCO is not usually directly involved in that process. That's something the insurer is doing. But what we see from our side is usually when something's happening not tied directly to an appointment, it's because the worker's been seen and the doctor said, okay, they can do this, but they can't do this. And then in a lot of cases, the worker just tells their employer back at that, and they go back to work and everything's in agreement. Usually when the bona fide job offer is involved, it's because the patient says, I still don't think that's okay, and I don't want to do it. And so then the employer's putting that together, and it gets sent to the doctor to look and say, this is what you said. So when you look at this job description and specifically what they're doing, is that okay in your medical opinion based on the most recent appointment? So if the worker's not being seen regularly, that's difficult to get a response on a provider from that. But normally when we're seeing it, if it's in between appointments, it's because there's kind of a discrepancy between what the employee thinks that they can do and what the doctor says they can do, or maybe they're concerned about something specific about the modified job they're being offered. honestly, I think the insurers are probably better poised to answer that question because they're more directly involved in that.
Joanna, you have your hand raised.
I did, thank you. I mean, I can speak to that from my personal experience, and I can say at least weekly, I have a worker call me who's received a bona fide job offer, and the very first thing they always tell me is, but my doctor took me off of work and I'm seeing him again in 2 weeks. I'm confused. And I have to explain that, there's been a change, your doctor's been contacted, and now there's been a change. And that, once I talk to the worker and they understand that, it's almost never a problem. I would say 99% of my workers accept those bona fide job offers. I think the other point would be that I don't see a lot of workers who go months without seeking medical treatment on accepted claims. It just doesn't happen. Do they go longer than 30 days? Certainly. But I don't see a lot of them go a very long time without it. I see very few bug letters, and when I do, they're oftentimes set out on like day 31, very short amount of time. So, I do see this happening between appointments, and, I think some of that engagement issue is not the workers failing to make appointments, but it is a lack of scheduling appointments from the medical offices.
Right, Maria?
I do have something to add. We frequently will come across cases where the physician will change the job release in between visits. Usually what we'll do is call the physician and provide some additional education, and the physician may wind up saying, or may have said, that a worker can't return to any level of work based upon what their understanding is of the job and what the worker is reporting to them about their capacity. But then when we point out perhaps what a patient has been doing in physical therapy and their demonstrate capacity there, and provide the education that they don't have to say that so cannot return to the level of work, they should specifically say what the worker is able to do, and then leave it up to the insurer to see if they can come up with a bona fide job offer to meet those capacities that are documented. So yeah, in between visits, we'll have the doctor send in a revised work release based upon the demonstrated capacities.
Thank you.
I have a follow-up from Ms. Patrick, if we're there. You good? Okay. You said that most patients are seeing their doctors regularly, and you can't say it's 30 days. What time frame can you say?
It varies greatly depending on the different doctor's offices. I cannot say, I haven't taken a survey of how long it is, but I think it's probably at least, usually every 60 days, except if it's post-surgical, which would sometimes be longer, or if the provider is waiting on something and there's a delay in getting it. Oftentimes the providers will say, go to 6 rounds of physical therapy and then come back. And the problem is that outside the MCO, there's no pre-authorization required for physical therapy, so it oftentimes takes a long time for the worker to get in. With MRIs, those do have to be pre-approved, but getting those scheduled can take time sometimes. So, it does vary greatly. I would say the regular routine case that's going along, I think most patients are seen within 30 to 60 days between appointments, unless there's something comes up like the provider cancels or is on vacation, which also happens a lot, especially with COVID.
Right, and then I also want to bring up the Dr. Dodger comment that you made. I think there's been examples of it existing, right, upon occasion. And that even one issue, if we address it, would it not improve the system and look qualitative versus quantitatively to improve our workers' comp system for everybody?
I don't believe that having a rule that will trap compliant workers and prevent them from getting time loss benefits on accepted claims just because an appointment is scheduled out longer than whatever time period might be decided on, I think that does more harm than the few workers who have not been quantified at all who might not be engaged in their care. We're talking about thousands and thousands of workers who could lose their benefits and lose their financial support through no fault of their own, just because we put in an arbitrary rule to capture those few individuals who are not engaging with their care. The tools that exist could be strengthened perhaps, but an arbitrary number would be so detrimental to the majority of workers that that would be a bad decision to make just because it helped a few workers engage with care.
Jennifer. Oh, Matt, sorry. Excuse me.
This is Matt. I just had one question that came up is, we don't know really what the frequency of visits are. It doesn't seem like anybody's really collecting the data, but with the electronic medical record, that should be very, very easy. So I'm wondering who we would go to pull that data from the electronic medical records, because it would be just a matter of workers who are engaged in the system, and then we can, the EMRs will tell us what their frequency of visits are and whatnot, so we could get, that wouldn't be a heavy lift, I would think. Because a lot of this, right, I haven't heard really anything compelling of, we see this percentage of folks who are not staying connected with care for this amount of time, and the outcome is this. And that, I think, would be really important information. So thank you, and then, yes, I'd be curious to hear Ms. Flood.
Oops, sorry. My clicker. There you go. I just want to share anecdotally the examples that Giovanna has provided is what our office does see. Specifically, one of the ones that came to my mind was the whole modified job offer, where the worker calls and says, hey, my doctor said I couldn't work, and now I'm being told there's this modified job offer. To me, that is a tool. If the true concern is ongoing treatment and communication with the worker and the medical provider, I do understand Elaine's comment that what medical provider would agree to a modified job without seeing the worker. It does happen. I believe it happens every day. But if a provider is hesitant on doing that activity could encourage an appointment to be made, a communication to be made. My concern is there are so many, in my opinion, there are so many tools that are out there. True, they could be improved likely to help with the communication, but putting it all of a sudden the worker's time loss is cut off and they have to work to get that, meaning they might not be able to pay rent, they might not be able to pay daycare in order to go to their modified job, is a little drastic. And I do feel, no data it seems like there should be data out there, but I think we really are talking about a very small population of workers that may be dodging the issue, and in putting together all the tools, we should be able to, insurers should be able to address those workers who are falling into that. Totally agree with Giovanna, taking the drastic as to, okay, well, we're going to fix the issue for those few workers, and having that impact the vast majority of workers is really harmful. And I understand, it's like, oh, you can get in every 30 days. And within the MCO systems, when they have those doctors on contract, where that expectation, keeping in mind it's an expectation, it's not a requirement. I'm sure that there's plenty of times where the worker is post-surgical, is told, hey, go to PT, and then come back and see me. That is going to be more than 30 days, no doubt. And if the worker were to see a provider that wasn't the attending physician, I can understand where an adjuster would think, well, the attending physician didn't authorize time loss, so we're still not going to be paying time loss. Again, that could get worked out, but in the meantime, the worker is not receiving that income, and it is impacting their life as well as their families. So I just wanted to share that.
Thanks, Jennifer. All right, so Matt, Sarah. I think I've got some of my follow-up to-dos for the next meeting there. And I just from looking at my notes from requests that came from the first meeting. So the invitation for MAC is actually literally being drafted right now. So I did get a text about that. So that's in the works on that. We will have some additional provider groups that will likely be at next Thursday's subcommittee meeting on that. And I will reach out to the Oregon Medical Association again to talk about that. And perhaps we will bring some more from individuals that deal more like on case management, scheduling, et cetera, to kind of give that perspective as well, since some of those issues.
Teresa, I'm sorry. Before
Yes.
we do the
Yeah.
summary and the follow-up, can we work through the table that was provided, the extract of the WCRI 2022 state laws, and see what other questions we need addressed there?
Sure, we can do that. That is not on the website right now, but I happen to have them here. So for those in the audience and so for everybody, I will upload those into the chat right now. These are both charts from the Workers' Compensation Research Institute. And, okay, so I think let's make sure they're both been uploaded. Get copies in front of me here. So, so for those in the audience, in between meetings, WCD generated both of these tables. It is a state by state, well, I would say jurisdiction, because it is not just the United States. There are some, there's information as well in some of the Canadian provinces as well. So the first one that I have uploaded, which is, let's see, I believe that one is on time loss. So I'll make sure I'm not speaking out of turn. As you can tell, it's quite comprehensive. What this does is that it outlines circumstances from state to state in which temporary time loss can be discontinued, such as when the worker returns to work, if they're released by a medical provider. Upon written notice, there are some states that allow for such, and then also kind of other criteria there. And those, as you can see, the footnotes are quite comprehensive because it does include some explanatory, some clarifications, and also in some lines it also states specific statute or rule for that particular state. The other chart is focused on in regards to medical benefits and the method of physician selection. So for example, if there's limitations on medical treatment for specific provider groups, if there is a fee schedule in place for reimbursement to the provider, who has the ability to do the initial choice of the treating physician, if it's just the employer or employee, or if it's a hybrid, and also circumstances in which the employee can change their treating physician is how it's identified here for us. It's attending physician, and also any limitations on requesting second medical opinions on that. So I know it covers some of the topics, but it doesn't. I think it looks like it's very deep, but yet it's very broad and wide at the same time. That's by my description of it.
Right. So I know it doesn't address California has 45-day time loss provision.
Yes.
And then also Oklahoma, my understanding doesn't address that they can, if a worker abandons treatment for 60 days, it will be terminated. So I feel like we're not getting to the full information on what other states are doing, which, I think the table is helpful as a starting point, but there might be additional information we could glean if we ask specific questions.
That is correct, and I was to say I may be speaking out of turn, WCD, so please chime in if I'm wrong. So yes, it can be about questions back to WCRI. It could be questions that are asked via WCD to other workers' compensation regulators across the country, that sort of thing. So I think once the questions are determined, we in turn can try and figure out the best entities to ask and go from there. Or even looking at taking from this kind of drilling, actually looking directly into their regulatory, like their statutes, rules, etc., for more clarification there.
Matt had a good point that maybe the data was there, just not included. Is that a worthy question to ask as well?
It's a great question. I don't know the answer to that. I think the answer probably is it depends on what the framework of the it's the set of questions.
Yeah, this is Matt. I tried to look into the California one. I think what it may be is this is actually what is, what conditions you can terminate, and I believe in California that may be the situation is that 45 days doesn't lead to a consequence of termination of the benefit. But I would be curious to see if somebody else can figure that out, and so I don't know which questions we would want to ask to be very specific, or to look whoever put this together if they did look into it and there was just nothing there.
Okay. Hi, Sally.
Lisa, hi. And I don't know that I can give specific information, but I believe we were looking for information that had already been published, and so I don't know what exact questions the WCRI asked for to get this information that we copied this table from. But if there are specific things about specific jurisdictions, requirements you'd like us to look into more, our policy folks can take a stab at that, but we'll need to know more about what you all are needing us to look for.
Would we like to address questions now, Matt, or how should we do that so we can get the accurate information on what other states are doing?
Yeah, it seems like looking at how comprehensive this is, it should come down to just one or two very basic questions, right? About I guess it's frequency. Is there and that's where I always struggle with how you frame the question, but is there a requirement on frequency of visitation with attending physician? And is there a consequence associated with that?
Like, how long can an attending physician authorize time loss between medical appointments? I think that's that question, right, Matt? Or
yeah, that seems totally appropriate.
Can a physician authorize time loss without an end date on their authorization? And yes. Is it an end date prescribed by statute or rule? If yes, is there an event or action that terminates the authorization? I think that leads to, the termination and what happens.
Those sound much better than mine. Well framed. Thank you.
Okay, I think I've got the notes down. So what I will do is I'm going to ruminate that kind of, to put together some sample questions based upon this piece of the conversation. I'll work with WCD staff on it, and I'll email it to both you and Matt and Sarah to make sure that we captured everything correctly before we do next steps. And so I'm going to check with Kara. I can do my first take of it this afternoon. So hopefully we should be able to get this done by maybe end of today, if not Monday.
It would be helpful to, I know it's a huge ask and a quick turnaround, but even a couple questions to understand better what other states are doing by the end of next week. So we know where we fall.
Okay. All right, I'll do my best.
That's a huge ask, Teresa. I understand. It's a huge ask, and I'm prefacing, yes, I get it and I understand.
Yeah, no, we'll do our best. And there might actually even be information too, again, going back to these tables, in which going back to the WCR, we can maybe perhaps see the methodology behind these
Yeah.
So no.
I mean, Matt had a good point. It might already be there. It just didn't get included.
Exactly. And if we ask directly, it should be, it might be within, they may have it in their possession, just not published here. So, but if we're on it, I've actually got seen a couple of texts come in, so we'll get that over to you ASAP and get that process going.
Thank you.
Thank you very much.
You're welcome. The other piece, actually, and it's probably for WCD, and I'll work with them as well. One of my bullet points was in regards to, this came up during the first meeting about the whether there could be an estimation of the number of bug letters, that were sent to injured workers due to non-engagement. If that's something that's measured, if it's out there.
I would be interested in that, but I believe in one of the meetings it was, and this may have been earlier in the year, it was stated that those aren't tracked. But if that is a possibility, that would be good data, I think.
We do have some data we're putting together. We can pull the number of administrative closures that the department receives that are coded that way. So we do have numbers on that. We'll be able to provide that.
Excellent, thank you.
Okay, I think that's all I've got. Actually, if anything else, going back to the provider and MCO conversations, is there any particular group that has not spoken or I've not mentioned that I'm having conversations with or and such that you would like me to send an invitation or remind them of invitation to be at the next meeting?
Tracy, you spoke about the ombuds offices.
Yes.
And I know Jennifer's here, but
Jennifer's here, yes, and Caitlin Breitbach is here from the ombuds for small business. So she is here. Hi, Jennifer.
No specific questions. They were mentioned. We've heard from Jennifer, but I don't believe we've heard from the other office.
Okay.
I am here. I'm taking everything in, and I just was invited to this meeting about a half an hour before it started. So I'm reviewing the documentation, listening to the comments, and then I hope to maybe if I have any questions or anything like that, reach out for future commentary as we kind of move forward.
Yeah. And Caitlin, if you have any questions too about things, feel free to reach out to me. We can have an offline conversation too.
Okay. Great. Thank you.
Reach out to see what the subcommittee's been doing. Okay, great.
And just so I'm clear, there would be ideally somebody from the MAC at the next week's meeting if they're available.
Yes.
But you had also reached out to folks from OMA.
Yes.
Who are on that? Okay, and so maybe we'll have a couple of positions who.
Yes, and also clinical staff possibly. That is a possibility. So we're gonna So the thought is and I know Courtney is here. I'm not gonna have her. I'm not calling on her to speak, but we are gonna have a conversation to talk about next steps and what can be done, what resources are available to help you in your deliberations.
And Teresa, in that, I'm really interested in their opinions on how often they want to see workers and how that, to aid in their recovery.
Okay.
So we can focus on, what they prefer doing would be helpful.
Okay. Great. This is very helpful.
Do you agree with that, Matt, or is that, yeah, okay. I don't want to speak out of scope for our
No, I think it's important to hear what the providers have to say for sure.
Okay. Going through my notes of the requests, so I think that covers it, and we've got our new additional directives from today, so we'll get that going on that. So, I was going to say, Matt, Sarah, is there anything else for the good of the order? Or?
No, I just thank you all for your time and effort and energy. This is a complicated issue, one that MLAC has asked us to address to ensure we're doing the best possible outcome or ensure the best possible outcome for our injured workers. So we appreciate all of your time today.
Thank you very much. Yeah, and I have nothing else for the good of the order.
Okay, so our next meeting is going to be, subcommittee meeting will be next Thursday, September 22nd at 10 a.m. and we will be issuing the agenda as quickly as we can via our usual channels. So there's that. So with that, thank you everybody. Happy Friday. Have a good weekend.
Thank you.
Thank you so much.